Hello and welcome to Covered. We're the COVID Vaccine Equity Research Dialogues from the Leonard Davis Institute of Health Economics at the University of Pennsylvania. I'm Allison Buttenheim, here with my Penn colleague Harold Schmidt, and our guest today is Jennifer Tolbert. She's the Director of State Health Reform at the Kaiser Family Foundation and an Associate Director for the Program on Medicaid and in the Uninsured. We're at a really interesting point in the vaccine rollout. Almost every state is getting to the point where everyone 16 and over is eligible. This is obviously going to have enormous equity implications for who has access and who's going to show up to be vaccinated. Let me turn it over to Harold to kick off our discussion with Jennifer.
So, this week is a very important and exciting week. We are opening vaccines for all, and that should be to the benefit of all, but it's not really clear that it will be, given where we are. And that's because not all states are equal. So we have big differences in terms of vaccination rates across states, and also big differences in terms of the share of disadvantaged people in states. So that means it's particularly concerning, or we have to pay attention to states that have larger shares of disadvantaged people and below average vaccination rates. And the Kaiser Family Foundation has done a lot of really interesting data, especially on differential vaccine receipt by racial and ethnic groups. And Jennifer, maybe you can just kick us off by telling us where things stand.
Yeah, so we have been looking at the vaccination data and the data that's being reported to the CDC, the Centers for Disease Control and Prevention. We have identified some equity issues. Black and Hispanic people are getting vaccinated at lower rates than white people. And that is the case across the board, across all states. And those gaps have persisted. There has been intentional focus on addressing these equity issues, but we continue to see the disparities in vaccination rates.
Jennifer, are you able to tell in your data whether those gaps are driven by access or hesitancy or some combination?
It is likely some combination. We have separately been doing polling and surveys of individuals to determine vaccine enthusiasm among people to get the vaccine. And we are seeing among racial and ethnic groups decrease in hesitancy rates over time. So when we compare people's responses in December to the responses on our most recent survey, which was in March, we've seen a decline among people of color who've indicated that they are either definitely not going to get a vaccine or will only get it if required. So those data suggest that some of the disparities we're seeing are being driven by other barriers, that individuals are interested in getting vaccinated, but they may be facing barriers such as transportation, technology barriers, language barriers, or other issues that are preventing them from getting vaccinated.
Jennifer, one other thing that I wondered if you could talk about too is at the beginning of the year when the CDC first flagged that we had these discrepancies across racial and ethnic groups, it was also clear that only for half of people who were vaccinated did we actually have data. Where is that at this point? How much do we actually know from the data that you and colleagues use about people's race and ethnicity?
The data, while it's improving, is still problematic. According to the data that is reported by the CDC, known race and ethnicity is only available for about 45% of the vaccines that have been administered. When you look at the data at the state level, there is variation, and some states do better than that overall 45%. But there still is variation in the quality of the data and differences in how states are reporting things like ethnicity, particularly Hispanic ethnicity, that make it difficult to directly compare rates across states.
Is there any signal that the missingness on the race ethnicity data actually helps with access? Are people reluctant to have to sort of register for a system or, answer questions at the time of vaccination about race ethnicity that actually creates friction in the system?
There may be concerns there. Typically, the state reporting systems or the registration systems do allow for someone to select other or refused. So that is typically an option for people. And we are seeing high rates among the data of either other or multiple races, much higher than is reported in other racial and ethnic data.
So one of the things that's really fun to do on the Kaiser Family Foundation site is, play around with the data and do some cross-state comparisons. We've been talking about race ethnic gaps in coverage within states, but you can look, for example, at for all the states, the share of population vaccinated with one or more doses. It looks to me, eyeballing it, like New Hampshire is doing the best. They are at over 50%, 52%. And one of the lower ones, maybe the lowest, is Alabama at 28%. So there's almost a 2x difference in the best performing and worst performing state, at least in terms of this one metric of the share of population vaccinated with one or more doses. That's pretty extraordinary, a 2x difference at a jurisdiction, at a state level. What are some of the things we think are driving that? Is that public health infrastructure? Is that strong leadership at the state level? Is that logistics? Is that New Hampshire is a very, in some ways, very homogenous state, although a state with a lot of poverty versus, Alabama has a different race ethnic makeup. What is going into these large cross-state differences?
We have identified that the use of a centralized state-based registration system does facilitate access to vaccines. So, for example, New Mexico, which is one of the leading states in terms of the share of the population vaccinated, early on was one of the first adopters of a centralized website and registration system. And that people in the state attribute that as one big factor that has contributed to their success.
There was an interesting proposal just a few weeks ago in Vermont where policymakers decided, precisely because of the disparate impact on particular African Americans, Hispanic, and indigenous communities, to prioritize these groups before the general population, right? Now, the thing is, with Vaccines for All, that option doesn't exist anymore. And the question really now is, what are we doing about this? Do you have any sense of the acceptability of measures that we can take now, disadvantage indices, for example, to make larger allocations to communities and disadvantaged areas, or to reserve larger slots of vaccine appointments, even if you don't increase allocations, or to do targeted outreach and communication? What's your sense from where you're sitting of what the best strategies now are to prevent that scissor from getting apart even further?
I think all of the strategies that you mentioned continue to be needed. So even as states open up eligibility, they can continue to adopt strategies to target vaccine appointments or outreach to certain communities and certain populations. And I think those efforts are going to continue to be needed, more needed now than before, now that everyone is eligible and that the demand for the vaccine is going to grow. Obviously, supply is also increasing along with demand, so that is a good thing.
So we've had this pause on the J&J vaccine, given some adverse events and the interest in looking more closely at that. What's that going to do both to supply and to public sort of trust in and interest in that vaccine?
There is a great deal of enthusiasm among the public for the Johnson & Johnson vaccine because it is a single dose and you get immunity within 2 weeks. While this pause will limit the availability of the Johnson & Johnson vaccine in the near term, it is unclear whether it will have a significant effect on people's interest in getting vaccinated with this particular vaccine, given its other advantages.
One of the things I find really helpful in the Kaiser Family Foundation data is the state-by-state listing of who's eligible, and you all update that every week, and it's very helpful. We're at a point right now where almost everybody in almost every state is eligible. I saw just a couple of holdouts on that table this week. What is that going to mean for equity if suddenly really everybody 16 and over can make an appointment and get a vaccine, but we know there's differential access and differential sort of motivation and hesitancy? Are gaps going to widen in the short term?
Yeah, I think that's something we're going to need to pay attention to. I think there is a possibility that these gaps will widen. It is also possible that when you open up eligibility to everyone, that some of these gaps and disparities do shrink a bit. We have been analyzing county vaccination data that was recently released by the CDC. What we found initially, not surprisingly, it's consistent with everything we've seen to date, which is that there are disparities and differences. So counties that scored higher on these social vulnerability indexes, that had higher shares of people of color, had lower vaccination rates. We're going to be continuing to monitor and evaluate these data over time. And can we identify some areas where maybe things are going really well, where counties are ranking high on these social vulnerability indices, but also are vaccinating at higher rates? So what is part of their success? I will say one real success story that we have begun to identify, partly through this county data, but also through some other data, is the success in vaccinating American Indians and Alaska Natives. Some of the counties, the top performing counties, so those that are high on the social vulnerability index, but also high on their vaccination rates, are counties with tribal reservations or counties with large Alaska Native populations. And I think there's we're going to want to look at this kind of after the fact and really understand kind of what has contributed to the success there. I think the federal government's direct allocation of vaccines to Indian Health Service facilities has been a success, and the willingness of states to partner with those communities, with the federal government in getting these communities vaccinated has been a real success story.
And Jennifer, to your point about the Indian Health Services, right? There were dedicated allocations through the health services. So as you flagged initially, the current model is still that we're allocating to states proportionate to population. And that is not very helpful if states differ quite dramatically in terms of their shares of disadvantaged populations, as we see here on the slide, for example.
I think that's right. I will also say that the federal government made a decision to allocate vaccines to states based on population. And because we have our rollout, which is kind of state-based rollout for the most part, I think the decisions about how to allocate vaccines to populations and to areas within the state kind of should be made at the state level. So you can establish equity across states in terms of how you allocate the vaccine, and then leave it to states to make decisions about how to distribute the vaccine within their states to, hopefully target underserved and other vulnerable populations.
Well, I think that's a perfect place for us to wrap up. Thank you so much to Jennifer Tolbert from the Kaiser Family Foundation joining us today on Covered, COVID Vaccine Equity Research Dialogues with my colleague Harold Schmidt from the University of Pennsylvania. I'm Allison Buttenheim. Please join us next time.